تمام ممتاز. خلينا نبلش معناته. هلا هاي اول كيس عندي. 72-year-old patient evaluated for chronic dyspnea, slowly progressive over 12 to 18 months. Patient first noted dyspnea while walking upstairs. Now patient is noted dyspnea with minimal exertion. There is a chronic productive cough, grayish sputum. There is no chest pain or pedal edema. The patient has smoked 2 packs of cigarettes every day for the past 55 years and still smokes. He has a history of hypertension. هلا يعني forget about physical examination. يعني so far what do you think what's going on with the patient in your differential? يعني بلشوا بالترتيب بالطاولة بالترتيب. Yeah, just tell me anything يعني your differential just so far.
In our differential, the patient might have COPD with acute exacerbation, and less probability heart failure, but as he doesn't have lower lymphedema or chest pain, it is a less likely choice.
تمام. Do you think this is asthma?
Actually, it is less likely as he has the symptoms over months, and taking into consideration his smoking history, it supports COPD more than asthma.
Yeah, I agree with you. أول شيء يعني this is against asthma يعني الage. Number 2 اللي هي الأزمة usually it's more kind of intermittent symptoms rather than progressive symptoms over time. هلا خلينا نروح على physical examination. Physical examination respiratory rate of 24. أنا بصراحة في عندي مشكلة هون بالسكرين إنه I cannot see the من my face. But anyway, so the respiratory rate you can see عندك 24 and accessory respiratory muscle still include the mystoid. انتوا شايفين الكلام ولا لا؟
الجزء اللي ورا شاشتك لا.
مش عارف ليش هيك شيء. مش عارف من كيف اخفي هاي الشاشة. المهم he's using his accessory muscles. هلا during inspiration cardiac sounds are distant and are normal. I think yeah, and difficult to hear breath sounds. يعني he has distal breath sounds with an abnormal inspiration to expiration ratio of 1 to 5. Hello, what is the normal I to E ratio of inspiration to expiration ratio?
1 to 2 ratio.
Usually 1 to 2, yeah, like 1 to 1 or 1 to 2. But he has a prolonged expiratory phase, and there is a diffuse expiratory wheezing. I think with no cyanosis or edema, I believe. So actually, let me just put here. Okay. Yeah. So this, you know, this is his X-ray. ممكن حدا يحكي لي so هاي النورمال X-ray. This is the abnormal X-ray. ممكن حدا يقرأ لي الإكس-راي يحكي لي شو رأيه؟ معلش على صوتكم لو سمحت.
في عندنا فات الدايفرام، في عندنا هايبر انفليشن، في عندنا الميدياستاينال اريا تقريبا نارو due to hyper inflation في اللاين.
Yes, exactly. So narrow mediastinal area في lung hyperinflation. شايف كيف هون it's more dark. The lung itself is more dark. This is a sign of air trapping بالlung. هلا يعني شايف more dark than the normal X-ray. هلا the other thing is if you look here the diaphragm, you know, is flattened. We call the flattened diaphragm. This is also a sign of hyperinflation. هلا الريبس كمان it's more flat reps. Also this is a sign of hyperinflation. هلا تمام. This is his X-ray. This is his CT scan. One cut of his CT scan. What do you see?
التزمنا changes صراحة على الرايت سايد في سب برضه
subpleural bulla.
So he has a large bulla.
بس موجود برضه في عندنا اللي هي subpleural bulla.
So diffuse precipitال centrolobular emphysema. Centrolobular when it is inside the lung, precipitال when it's closed from the pleura, and also he has a big bulla. تمام. هلا هلا pulmonary function test was obtained. هلا his FEV1 was 50%. His FVC was 65%, and his FEV1 to FVC was 0.5. هلا his FRC functional residual capacity. His FRC زي ما بتعرفوا اللي هو residual volume plus expiratory reserve volume. So his FRC determined using helium dilution is 4.2, which is 100%, and his DLCO, which is diffusion capacity, is 35%. هلا بما إنه ال FEV1 to the FVC is less than 70%. طبعا احنا we don't go يعني when we go with a ratio, when we read an PFT, we don't go with a percent predicted. So يعني I should not say less than 70%, I should say less than 0.7 خلينا نحكي. بس anyway هون احنا ما بنحكي عن ال predicted, بنحكي عن ال actual ratio less than 70%. So what findings on physical exam correlates with a PFT finding. يعني من physical exam اللي حكيناهم, what findings correlate with that?
Prolonged expiratory phase.
Exactly. So he has a prolonged expiratory phase of 0.5. This correlates with a low FEV1 to the FVC ratio. It takes you longer time to breathe out. تمام. And what do you think about or what do these findings suggest about the airway resistance? شو بفكر الايرواي شو بكون الايرواي resistance بالعادة عند هذول المرضى؟
Increase high.
It's definitely increase. هلا ال بالعادة هذول المرضى شو المشكلة عندهم؟ ليش ال DLCO واطية؟ diffusion capacity واطية؟ الو؟ معنا اوكي تمام. بس انا عن الدي ال سي او ليش بكون عندهم الواطي الدي ال سي او هذول المرضى؟ معلش مش سامعكم. لا مش سامعكم بس على العموم هو لانه في دمج عندك بين هذا شو الدي ال سي بيعتمد على شو؟ بيعتمد على عده شغلات. بيعتمد على الغاز اتسلف، بيعتمد على يعني بيعتمد على اللنج فنتيليشن، بيعتمد على اللنج perfusion from blood، بيعتمد على الغاز اتسلف. هلا احنا هون في عندنا دمج بين الاولوفيولار كابيلاري ميمبرين من الانفيزيما، فعشان هيك بكون يعني surface area is damaged. So عشان هيك الدي ال سي او بكون هذول المرضى عندهم لو. إذا بشكل عام diffusion of gas across the membrane depends on a number of factors اللي هو characteristic of the gas, solubility of the gas, pressure gradient, surface area of the diffusion membrane. So on these patients with emphysema بكون عندهم surface area of the diffusion membrane is damaged, is low. هلا بكون thickness of the membrane, adequate ventilation and adequate perfusion. So in these patients بكون عندهم المشكلة اللي هي surface area. هلا the other thing is إذا نطلع back على ال PFT. one thing حكينا عنه إنه هذا المريض شفنا الإكس راي تبعته and we saw that he has hyperinflation of the lung most likely from air trapping. يعني شفنا قديش الإكس راي dark. شفنا diaphragm flat. Now when they measured this patient يعني by helium dilution they found his FRC. يعني you should expect لما بنحكي عن مريض عنده air trapping يعني his RV to TLC is high, should be high. بس عند هذا طبعا وال TLC نفسها should be high too. عند هذا المريض اللي هي ال RV مع ال ERV اللي هو ال functional residual capacity was normal. Now I don't know if you guys know about how do we measure PFTs, but when we do lung volumes, بالعادة we do have two methods. We have one of them is helium dilution, and the other one we call it a plethysmography. Now the plethysmography هون لما يحطوا المريض جوا الجلاس اللي هي البوكس اللي هو الجلاس box. They measure lung volume depends on the change in the volume inside the box. بس بيسكروا على المريض البوكس and they measure the change in the volumes. بيعتمد على المريض كم باخذ يعني the change in the volume within the box. هلا لما المريض يكون عنده مثلا claustrophobia and he cannot do that, sometimes they can consider doing something اللي هو اللي بسموه احنا بنسميه هون الهيليوم dilution. هلا الهيليوم نفسه it's a gas ما له رائحة. لما يتنفس المريض وهو بيعمل بالتست it's gonna go to his lungs بس ما بيروح على البلد يعني بيضل within the lung itself. It doesn't diffuse to the blood. So فبالعادة اللي بيصير إنه ال PFT technician بيحكي للمريض إنه تنفس 10 مرات مثلا in and out very deep breath. طبعا بيشبكوا المريض على التانك تبع الهيليوم اللي هو خلينا نحكي البوكس تبع الهيليوم وبيحكوا للمريض يتنفس 10 مرات in and out بحيث إنه يصير عندك equilibrium بين المريض والتانك إنه الكونسنتريشن تبع الهيليوم بصير واحد بين الاثنين. هلا عند هذا المريض specifically اللي هو عنده COPD أو emphysema وعنده big bullies لما when they measured اللي هي خلينا نحكي lung volumes عنده طلعوا normal. بس احنا حكينا بالاول انه we should expect this patient to have a big lungs like lung hyperinflation. So the question is why. I'm not sure if and if you got my point, but I'm gonna just show you how do we do that. هلا نحكي during the helium dilution test the patient breathed from a container with a known volume of gas. So خلينا نفرض بعرفش انتوا شايفين البوينتر تبعي ولا لا؟ شايفين البوينتر؟
شايفين.
هلا نفرض انه هذا هو اللي هو التانك تبع الهيليوم. نفرض انه هذول هاي رئة المريض. هلا احنا بنعرف جوا التانك هذا بنعرف شو الفوليوم تبع التانك وبنعرف شو الكونسنتريشن تبع الهيليوم. لما نشبك عليه المريض بنحكي له مثلا ياخذ in and out multiple times. At the end of the test, this is a connected system here. فانت by physiology that V1 خلينا نحكي انه التانك هذا بنسميه 1 والنيو سيستم اللي هو after we connected المريض بنسميه V2 اللي هو both اللي هو الرئتين تبعون المريض مع التانك. فبنحكي V1 times C1 اللي هو concentration تبع الهيليوم equals بعد ما شبكنا المريض equals V1 plus V2. V1 اللي هو حكينا التانك نفسه V2 اللي هو رئتين المريض times C2 اللي هو النيو concentration. هلا احنا we get the new concentration من التانك نفسه يعني we take a sample ونشوف شو الكونسنتريشن تبع الهيليوم. هلا احنا الفوليوم اللي interested in اللي هو V2 اللي هو رئة المريض. يعني هذا احنا this is why we do the test to know what's the lung volume. فاذا سويت المعادله هون بيكون V2 اللي هو اللي احنا interested فيه equals V1 times C1 divided by C2 minus V1. هلا احنا بما ان احنا we interested in V2، هلا after we do the test بنخلي المريض يتنفس in and out. هلا we already احنا know V1 from before, we know C1 from before. The only thing we need is C2. So we take a sample from the tank. We are assuming C2 it's equal between both. And we measure C2, then we measure the V2. خلاص نكون نعرف كل شيء عنا هون. هلا شو المشكلة بهدول المرضى؟ إنه لأنه عندهم air trapping obstruction, the gas is not going to go. It's not, even if the patient takes like 10 breaths in and out, the gas is not. It's not gonna gonna be equal concentration between both. فلما تيجي تاخذ انت السامبل بنهايه التست بتكون ال C2 اللي بتكون ال C2 اللي هي new concentration is falsely high لانه ما صار زي equilibrium between both اللي هي التانك واللنج. فلما يكون C2 high, just look at this formula here. لما يكون C2 high ال V2 بتكون falsely low. Does that make sense? مش عارف هاي واضحة النقطة ولا لا؟ مش عارف، أنا مش سامع.
واضحة، هي صعبة بس واضحة.
تمام. هلا زي ما حكيت لك اللي هي فكرة الموضوع إنه تتذكر هاي الفورمولا هون اللي هو ال V1 times C1 equal new volume اللي هو both lungs and the tank times the new concentration. احنا اللي interested فيه اللي هو الفوليوم تبع اللنج، ولما نحطه لحاله هون if you think about it بهذا المريض C2 it should be equal between the tank and the lung, but هون لأنه المريض عنده COPD emphysema ما صار enough time for this equilibrium to happen. فعشان هيك C2 بيكون falsely high وبالتالي lung volume is falsely low. فعشان هيك عند هذا المريض ال FRC طلع عنده 100%، مع انه احنا المفروض نتوقع انه بما انه عنده air trapping انه يكون اكثر من 120%. هلا احنا بنحكي عن lung volume if the patient has a TLC اللي هي total lung capacity more than 120%. انت مش عارف اخذتوا محاضرات PFT قبل هيك او عملتوا PFT sessions؟
صراحة لا، يعني صراحة
طيب.
أكثر تحديد نتعامل مع PFT مش إحنا صدقا.
طيب خلص بلكي المرة الجاية حكينا عن PFT معناته.
إن شاء الله.
خلص ماشي. هلا ماشي. في حدا عنده أي questions؟ طب خلينا نروح just to save time، خلينا نروح على another case. تمام. أنا بدي في ممكن حدا فيكم to read please.
Okay. A 48-year-old female is evaluated for increasing shortness of breath. She first noticed dyspnea approximately 6 months ago when she was hurrying to catch a bus. Since that time, dyspnea has slowly progressed. She now feels short of breath when walking at normal pace after a distance of 20 yards. There has been no chest pain, cough, orthopnea, or DMDs over the last 2 months. She has noticed swelling of her ankles bilaterally. She is a lifelong non-smoker. A comprehensive occupational and environmental history reveals no significant exposure. Her past medical history is notable for laparoscopic cholecystectomy. This was performed because of persistent right upper quadrant pain and gallstones. Other past medical history is negative. Family history is remarkable for a mother with diabetes and breast cancer and father with psoriasis. Both parents are alive and in their 80s. The patient is an only child. She takes no medication and otherwise has no drug history with drug or alcohol use.
Okay, تمام. هلا what do you يعني in these patients you know, what's your differential? So basically, we are talking about 48-year-old, just to summarize things quickly, never smoker, who has progressive shortness of breath over 6 months. And المريضة ما عندها chest pain, no cough, no orthopnea, no BND. هلا كمان yeah, that's the only thing يعني I would say, I would summarize things. So what do you think in this case? What's the differential? تمام ممتاز. So pulmonary hypertension, interstitial lung disease, perfect. Less likely in this patient, you know, unlikely to be COPD, although, you know, for example, let's say if she has alpha-1 antitrypsin deficiency, you know, she can have COPD, but less likely to have COPD. This is less likely to be asthma, again, for the same reasons. You know, it's not intermittent, it's a progressive disease. وكمان she doesn't have any cough or wheezing. تمام. خلوا على الexamination. هلا her vital signs, they're all okay. Her heart rate just slightly elevated, like 105. هلا الexam, she has an abnormal jugular vein distension. She has clear lungs with normal inspiratory to expiratory ratio. Her cardiac exam with a loud second component, P2, of the second heart sound. هلا second heart sound, if you remember, we have S1 and S2. So S2 has A2 plus P2. هلا A2 should be اللي هو closure of the aortic valve should be louder than closure of the pulmonary valve لأنه البريشر أعلى بالليفت side صح؟ But when you have a loud second component P2, when you have a loud closure of the pulmonary valve, that's indicative of increased pressure on the right side. هلا without murmurs or abnormal sounds like S3 or S4. هلا she has bilateral lower extremity edema. So what's, you know, has your differential changed so far?
Yeah, sure. بس بيقولوا لها hypertension مثلا.
تمام. هلا what do you see here?
A prominent vascular marking.
Yeah, definitely. So prominent vascular markings. يعني one of the يعني طبعا صعب تعرف 100% بعد الاكس راي بس one of the differential could be also lymphadenopathy يعني there in that area that looks like that like hilar lymphadenopathy. Yeah. هلا when you suspect somebody has pulmonary hypertension, first thing you do a screening echocardiogram before you do anything else. هلا in the screening echocardiogram they will give you an estimate of their PA systolic pressure, pulmonary artery systolic pressure, but it doesn't give you an accurate 100% accurate diagnosis. So this is why you have to confirm the diagnosis by doing a right heart catheterization. So basically what we do usually, most likely, we go through the IJ, the internal jugular vein, and we put this, what we call Swan-Ganz catheter or a pulmonary arterial catheter. We go through the IJ to the SVC, from the SVC to the right atrium, then to the right ventricle, then go to the pulmonary artery, and we measure the pressure there. So if the pressure, if the mean PA systolic pressure more than 20, like 21 or above, that's confirmed the diagnosis of pulmonary hypertension. This is the measurements of the patient pressures at rest. So when she was sitting there during the right heart catheterization, so her RA pressure was 12, you know, and so normally the CVP pressure or the RA pressure should be less than 8. Now her RV pressure was 60/12. This is systolic, this is diastolic, and we have the normal here next to it. So it's high, and pulmonary artery pressure is 60/30. And with a mean of 40. احنا حكينا طبعا الnormal mean PA pressure should be around 15, but to call it pulmonary hypertension should be above 20. So she definitely has pulmonary hypertension. Her wedge pressure, capillary wedge pressure is 12 and normal should be less than 18. Her cardiac output is 3.5. What's the normal cardiac output? Usually around 5 liters per minute. So they said additional measurements at rest shows that the dead space fraction is 30%. What's the dead space? Do you guys know what's the dead space fraction?
Actually, no. No.
هلا dead space fraction basically انت when you breathe air you breathe around, depends on your height and you know body surface area and gender, you breathe something called tidal volumes, huh? هلا tidal volume, let's say 500 ml, this doesn't all participate in gas exchange. So the amount of air that does not participate in gas exchange, we call this dead space fraction or dead space. The reason why the gas doesn't participate, two reasons. First of all, we have something called anatomical dead space. For example, your mouth, your trachea, your bronchi, all these things, you know, they don't participate in gas exchange. But those we call them anatomical dead space. هلا عندك physiological dead space. Physiological dead space اللي هو في عندك some of the air goes especially into the upper lobes, you know, both upper lobes, the lungs. هلا most of the perfusion and ventilation happens in the lower lobes of the lung just by gravity. تمام. هلا فعندك less amount of blood goes to the upper lobes وبالتالي that air اللي هو بيروح على upper lobes doesn't always participate in gas exchange لأنه في less capillaries there. فبالتالي بيصير عندك something called physiologic or alveolar dead space. So both alveolar dead space and anatomical dead space, we call them physiological dead space. طبعا normally if you breathe around 500 ml of air, 30% of that, like يعني بنحكي احنا عن almost 150 ml of air doesn't participate in gas exchange. So we call this dead space fraction 30%. Now, when we did the right heart cath on this patient, we also asked her to exercise while we are taking we take the measurements again. So during exercise, so her PA pressure went up to 80/50 with a mean of 60. Remember, before exercise, her mean was 40. So her PA pressure went up with exercise. Her wedge pressure also, pulmonary capillary wedge pressure, went up from 12 to 15. Her cardiac output went up from 3.5 to 4.5. And her dead space fraction went up from 30% to 35%. Okay. Now, you know, okay. هلا بحكي لك in health, what should the pulmonary vascular resistance during exercise? هلا based on this reading, you know, do you know how do we measure pulmonary vascular resistance?
Right sided heart cath.
You know, it's something that you need to calculate. Do you know what's the formula? Do you know what's the Ohm's law? Ohm's law. في حدا بيحكي بس أنا بصراحة مش سامع بس anyway. طب أنا يعني أنا بصراحة مش سامع بس anyway. هلا
في علاقة مع الكومبلينس والراديوس والبريشر، بس الفورمولا نفسها احنا ناسيين كيف بالضبط، بس في انه يعني ريليشن مع الكومبلينس والراديوس كمان ثاني.
تمام. هلا Ohm's law itself V equals IR correct. V اللي هي الفولتج. هلا احنا بنحكي عن electricity. V is voltage, I is current, و R is resistance. تمام. يعني I want you to write this down. هلا V equals IR. هلا احنا when we talk about fluids, right? احنا we are talking about fluids. هلا V اللي هي الفولتج. تمام. This is when we talk about fluids, this will be delta P, which is the change in the pressure. يعني إذا عندك tube وماشي من خلاله fluids اللي هو البلود, you need the difference between the two pressures على two sides of the tube. تمام. هلا I اللي هو current بالelectricity, this will be your this is the flow basically in the fluids, and your flow here is your cardiac output basically, and R is the resistance. تمام. فأنا سؤالي كان لكم how do you measure the pulmonary vascular resistance اللي هو بسميه PVR. تمام. فأنت من خلال هاي اللي حكينا delta P equals cardiac output times R, معناته PVR is equal delta P over your cardiac output. تمام. هلا احنا وين عندنا احنا in general we have two resistance بالبادي. في عندنا شيء بنسميه systemic vascular resistance وفي عندنا pulmonary vascular resistance. تمام. احنا هلا هون we are interested بالpulmonary vascular resistance بهذا المريض. فال PVR equals delta P over cardiac output. We already know the cardiac output اللي هو اعطانا اياه هون اللي هو 3.5. هلا delta P هلا احنا when we talk about pulmonary vascular resistance what are the two حكينا في عندنا اللي هو التيوب, حكينا فيه انه في عندنا ممكن نطفي هون, حكينا في عندنا two sides of the pressure. شو هم الدلتا بي اللي احنا interested in here؟
على الفيرست اللي هو at the mouth opening, والسكند اللي هو at the alveolus level.
I'm sorry, say that again.
الفيرست one اللي تكون على الماوث اوبننج, والسكند اللي تكون على الالفيولر ليفل.
صح. so اللي هو الاول اللي هو المين بي اي بريشر اللي هو البلمونري ارتري. انت اول السيستم عندك اللي هو البلمونري ارتري, فالبريشر اللي هو المين تبعه المين بي اي بريشر. تمام. ماينس اللي هو على الليفل اوف ذا كابيلاري اللي هو البلمونري كابيلاري ويدج بريشر. تمام. over your cardiac output. فاحنا عندنا هون المين بي اي بريشر is 40. تمام. pulmonary capillary wedge pressure is 12 over your cardiac output اللي هو 3.5. فانت if you use the calculator, تمام, 40 times 12 over 3.5. I'm sorry, 40 minus 12. 40 minus 12 over 3.5 equals 8. So عندنا ال PVR pulmonary vascular resistance is 8. هون بنسميها Woods unit pulmonary vascular resistance. هو 8 Woods unit. هلا normally pulmonary vascular resistance should be less than 3. تمام. But 8 is high. And this is one of the characteristics of pulmonary hypertension. You have a high pulmonary vascular resistance. تمام. هلا normally بدي أسألكم سؤال. when you exercise normally, what happens to the pulmonary vascular resistance?
It should decrease.
It should decrease, yeah. Do you know why?
The smooth muscle, it should relax.
Exactly. So you secrete things like, for example, nitric oxide, which will cause smooth muscle relaxation and vasodilation. So, and that's one reason. The second reason, during exercise, you recruit more capillaries. So you recruit more capillaries, so you will have improved perfusion of the lung with these capillaries. And طبعا زي ما بتعرفوا هذول capillaries, they are kind of parallel. So if you measure the total resistance, تمام, of these capillaries, they will decrease. When you have a parallel parallel capillaries, the total resistance decreases when you add more capillaries. So مع إنه الفلو cardiac output normally should increase, but also اللي هو pulmonary vascular resistance still it will decrease لأنك أنت you recruit more capillaries and you have more vasodilation. تمام. هلا شو صار بالبي في ار عند هاي المريضة؟ This is during exercise. So her إذا بدنا to measure ال PVR again اللي هو حكينا دلتا بي اللي هو mean PA pressure اللي هو 60 minus الويدج اللي هو 15 over your cardiac output اللي هو 4.5. That's 45 over 4.5. So this is 10. So her PVR, pulmonary vascular resistance, went up from 8 to 10. هلا احنا we just said that the PVR should go down, صح؟
Yes.
هلا طب شو اللي صار بهذول؟ شو صار عند هاي المريضة؟ شو المشكلة؟ ليش ال pulmonary vascular resistance went up instead of going down?
There is a problem in the smooth muscle relaxation or in the excretion of these mediators that promote relaxation.
Exactly. So this patient, she has pulmonary hypertension, so she has an issue with a smooth muscle relaxation, so she cannot vasodilate properly, and also she cannot recruit more capillaries. So with the increase in the cardiac output, which you expect during exercise from increasing the heart rate and contractility of the heart, so you increase in the cardiac output, but she didn't recruit more capillaries, she didn't vasodilate. So instead of her BVR going down, it went up. And this is kind of like also, you know, confirm the diagnosis of pulmonary hypertension. So what do you think about the dead space fraction? It went up. So what's normally should happen to the dead space fraction during exercise? طبعا انا حكيت لكم شو dead space صح؟ شو يعني during exercise شو بتتوقع يصير بالdead space؟ المفروض ينزل يقل، لانك انت هلا الاناتوميكال dead space is going to stay the same لانه هو الماوث والبرونكيا برونكاي will stay the same, so anatomical dead space will stay the same. Now the alveolar dead space بقل. ليش بقل؟ لانه انت during exercise normally انا بحكي you recruit more capillaries, فالperfusion بتحسن بالupper lobes of the lung، بس عندك perfusion اكثر during exercise، فبانه الperfusion بتحسن so الجاز exchange بتحسن بالupper lobes، فبشكل عام الديد سبيس بقل، بصير more gas exchange. فالديد space normally dead space during exercise can go as low as 20% from 30%. It can go to 20%. Now in this patient it went actually the opposite, it went up to 35%. And this is for the same reason we just said لأنه هاي المريضة she's not able to recruit more capillaries. وشو اللي بيصير عند هاي المريضة؟ she's exercising, she's utilizing oxygen, and she's not able to improve her gas exchange, so she become hypoxemic. هلا when you become hypoxemic, the lung, what happens to the capillaries, or what happens to the vascular vasoconstriction? So we have something called hypoxemic vasoconstriction in the lung. So when you become hypoxemic, you know, the lung itself will cause actually vasoconstriction. But this will even make things worse, means that it will increases your PVR because of the vasoconstriction, and will also prevent, you know, the capillary, you know, will prevent from recruiting more capillaries. So the dead space fraction, so you have worsening, what we call VQ matching. I don't know if you remember the mechanisms of hypoxemia. One of them is shunting, one of them is like diffusion impairment, one of them is VQ mismatch. So in these patients with pulmonary hypertension, they will have a worsening VQ mismatch. So they have worsening hypoxemia. والديد سبيس تبعتهم بتزيد بدل ما تقل. احنا we answered this question, we talked about this, we talked about this. هلا what happens to the patient minute? So during this patient, so during exercise, the patient PaO2 اللي هو ال partial pressure of oxygen in the blood decreased from 80 to 52 اللي هو صار عنده hypoxemia during exercise. How will the fall in PaO2 affect the PVR? حكينا عنه بالconstriction, hypoxemic vasoconstriction. So the PVR will increase. And what happens to the minute ventilation? So do you guys know what's the minute ventilation?
Respiratory rate times the tidal volume.
Exactly. So what happens to the minute ventilation during exercise normally? It will increase. So because you increase your respiratory rate. Same thing with this patient. So the hypoxemia itself, it will stimulate the, some chemo receptors على carotid bodies, and that will stimulate the lung to breathe faster. So this is why these patients are like, they are short of breath. They are breathing fast during exercise. So overall effect on the minute ventilation will increase. حكينا عن dead space fraction. Do you guys have any questions?
No.
And I have two more cases, but or at least one important case, but it's up to you guys if you want to continue or if you have work, I completely understand. If you want to continue, I'll be happy to continue. What do you guys want to do? No. Feel free to say what you have to do. مش سامعك شو حكيت؟
إذا في مجال نرتبها على مرة ثانية.
خلص إن شاء الله ماشي تمام. أنا عارف إنه بجوز الوضع صعب هيك إنه لا أنا شوي تأخرنا شوي منه بشغلة من البداية إحنا ما بلشناش على الأون تايم إن شاء الله next time تكون أحسن مثلا نبلش on time. maybe أنا ما توقعش، أنا فكرت إنه راح يكون الأكسس مثلا يكون أحسن للصوت وهي الشغلات بس I think if you guys have any questions please feel free to contact me إذا بدكم عندكم specific topics احكوا له ممكن تبعتوا له أو تبعتوا للدكتور رامي الأحمد we can arrange for specific topics PFT. I have a lecture about pleural effusions, PFTs, different things in pulmonary if you need something specific. تمام. بس you need to build up your as an internist you need to know at least about some PFT knowledge, some knowledge about COPD, common disease, COPD, asthma, pleural effusions, things like that. ماشي الحال. يعطيكم العافية.
شكرا دكتور.
عفوا. مع السلامة.